Okay, so we're going to read these and then probably also take some questions from out in the audience. This is the first one I see. Once the need for a kidney transplant is identified, how long does it take to find a kidney and do the transplant? Dr. Solomon.
Yeah, so there the answer is, the first answer is exactly like Ted's answer, and that is you have to be evaluated for one. We set a maximum of 6 months and aim for 3 months to turn a patient through that process. Then once you're on a list, if you have a living donor, we can do that transplant. We have to work up your living donor. So I would say from beginning to end, if you have a living donor, about 6 months. And if there are reasons, we can go faster. If you have to go on a list for a deceased donor transplant, if you have no sensitization, it really depends on where you are. And it behooves you to be very smart about this and look at waiting list times. Because for example, the waiting list in Los Angeles is, for the kidney, it's about 6 years. For a kidney in Los Angeles, but in San Diego, it's only about 3 or 4. So you can do a list, and there's a lot of strategies. I can talk to people afterwards.
The obvious follow-up, how much do they cost, and does insurance pay for it?
Yes, insurance pays for it. A kidney transplant now is about $36,000 to $45,000. So if you tried to pay for it out of your pocket, they would want about $100,000 for it. But it's also covered as an entitlement under Medicare once you're on dialysis, so that's not a problem.
Great. Is there any way that we could get somehow make the eye drops into contacts? Dr. Simpson is gone. We will need to parking lot that question. Who? I tell you what.
I'll follow up with her.
Yeah. Whoever.
Shannon, it's done. Ignore it. It's been taken care of.
Okay. Go ahead, Tracy.
Okay, in the kidney problem, polyuria, protein is dumped into the urine. Can protein be given in the form of protein bars and drinks to an athletic cystinotic safely? Can he take in too much protein? What is the maximum safe amount and that should be ingested through drinks and bars?
I believe Dr. Grimm had to catch a plane, but...
Well, I can answer that. Do you know, Jerry? No. Oh, okay. So you're talking about giving protein bars to someone with renal insufficiency?
To make up for polyuria.
Doesn't make sense.
Well, polyuria, no. Of course, that wouldn't work at all. But what they're talking about, I think, is spilling amino acids, the proteinuria. And that is very possible. Yes, that's what we do for patients with significant proteinuria. The problem is that in young children with renal tubular, the kind of Fanconi's proteinuria that they have, that's really, really hard to do, but it's all you can do. It's a high protein.
Is that why my daughter can eat an entire New York steak all by herself?
Absolutely. Yeah. Absolutely.
So let's take that one step further. So let's say we're not talking about young kids, we're talking about maybe teenagers who are looking to do, compete in athletics or bodybuilding or something like that.
If they at that point the teenager still has a native kidney with Fanconi's, that's what you do. You supplement with. You
just
with
eat
protein.
lots and lots of protein.
I would at that point bring out things like whey protein. You
Right.
get these. You go there to. I tell my patients go to Good Health or whatever your favorite store is and find one of these gigantic boxes with this huge muscular guy on the front of it.
Okay. There's a person that answered that question. Is that good? Okay, cool. How can you be sure a sibling donor won't be late developing a case of cystinosis? Dr. Schneider?
If the sibling does have cystinosis, it's going to be the same type as the child who you're dealing with, and that's nothing you really have to worry about. The other thing that amazed me is that heterozygote donors both kidneys seem to do as well as kidneys from people who are not heterozygotes for cystinosis.
So if you...
Because at one time we worried about that, a parent or a sibling who was also a carrier for the same disease, and they seem to do just as well as any other kidneys.
Thank you. And so essentially, if you have children who aren't showing symptoms of cystinosis already, and one of your children has nephropatic cystinosis, then they're not going to develop it. Correct.
As long as they're the same age.
Same age or older?
No, I mean.
If they're older, the same age or older than the child who's got is what we call proband, who has cystinosis, then you're okay.
Right. So if your youngest has cystinosis and your older ones don't, then your older ones don't.
Yeah. I'm going to ask one of my own because I'm standing here and I'm just thinking of it. And I'm sure I've asked it before. Stephanie, you give your speech so nicely, and there are a few different scenarios with the mice, but renal tubular acidosis, do those mice, are their tubes regenerating and being fixed? I know Dr. Graham yesterday said that once those are damaged, they're irreparable, but does your work show that perhaps they can be regenerated?
This is a very, very good question, and it's not a straight answer. A lot of people are working on that. I mean, can the tubers regenerate? We don't know. So that's why I don't know if it's a regeneration in my case or a preservation. What I showed is that when we transplanted old mice that were 9 months of age, so at that age there is a significant amount of degeneration of the kidney. If we have a high enough cells expressing cystinosis, we could have a good kidney function and a good... So at the end, when we analyze the mice, we rescued the kidney. So, but we didn't know how it was before because there is no way to know in the mice. So I don't know if it was still a preservation or if there was a regeneration. We are working on that because it's a very important question and nobody really knows. But what I know is that everywhere where it's a good kidney and a good histology, there are all these cells around the tubules, not inside but around. So I don't know if there is a, so the cells goes and try to keep the tubule working by giving the protein, exchange. We don't know yet how it works. But there is plenty of bone marrow derived cells around the tubes, and in all this area, the tubes are really good. So I don't know if they're regenerated or if they're good preserved. It's a very good question, and I don't know.
Thank you.
What's the ideal time? When do you know it's time for a kidney transplant?
So basically, one way of thinking about it is that the good news is kidney disease, kidney failure is not painful, and it's not, all you do is slowly kind of drift down. And so we might follow the clearance, which is a measure of the kidney function, and when it gets below 20% or 20 mLs per minute, you're around the time that you would start seriously thinking about a transplant. So by US law, we can list you whenever you're 20 or less percent of native renal function. So that's probably the best answer.
Thanks.
What efforts are being taken to have newborn screening for cystinosis? This patient or this person writes, so much damage could be avoided if children were tested at birth. First-born children with no family history suffer due to delayed diagnosis. Dr. Schneider.
Well, I know a lot of people have been thinking and talking about this. The last I heard, people felt that the cost of doing it would be more than what the gain would be. But the cost of doing it is getting less and less, and so I suspect that within a short time this will be happening. It won't just be cystinosis, but people will be testing for many inherited diseases at the same time. At the moment, I don't know of anyone who's doing this well.
Dr. Gal is working on that.
I know.
Yeah. So, yeah, maybe so.
Dr. Schneider, real quick, while you got the microphone, somebody wants to know, just out of curiosity, how high can cystine levels go? I think on the charts it only went so high as 6.0. How high can they go?
Well, it's a tricky question because it depends who's doing the measurement and how they're doing the measurement. We in the old days would often get measurements up as high as 10, but I think that the techniques of doing it have changed. A lot of it had to do with anticoagulation of the blood. And we always used heparin, and I'd always naively thought that heparin was a sort of a uniform compound. Now I know it depends on which Chinese farmer is mixing it up in his kitchen. And I think this has made a big difference. I don't think it makes much difference if it's up high. It doesn't mean that the child is worse off.
Right.
The important thing is how low you can.
But 10's about as high as you're saying?
Yes.
Okay, cool.
So yesterday, Dr. Mack spoke about the vitamin D. I realize he's not here, but that was compelling, and it makes me, as a parent, I give my kids calcitriol, but it makes me want to go out and buy some, just go to my pharmacy and grab some of the D25, which I know isn't the right thing to do, but could we be supplementing just as precautionarily is just too preliminary what he's doing.
So patients with kidney disease have a vitamin D problem. So the kidney takes 25-hydroxy vitamin D3, which you make through exposure to sunlight. So the more we're spending playing video games or staring at computers at work, the less sunlight we have. And so a big deal now is that many Americans apparently have a functional vitamin D deficiency even without kidney disease.
And that's not the 125, that's the 25.
They have a deficiency in 25-hydroxy-D3. Then the kidney takes the 25-hydroxy-D3 and it does another little enzymatic razzle-dazzle on it and adds a 1 and a 24, so it becomes 1,24,25 vitamin-hydroxy-D3. And that's calcitriol, and that's the activated form of it. And so when your son's taking calcitriol, you've basically gone one step past the vitamin D supplementation. So I wouldn't want to show any disrespect for Dr. Grimm, because I wasn't here to hear, or Dr. Mack. I don't know, I mean, he might have had some new data that I'm not aware of. There are some people who use a long-acting form of vitamin D with calcitriol, because it's short-acting, to create a kind of a flow that some people feel is a little bit more healthy. So you'd have to ask Dr. Mack specifically to address if he's got some new data.
The long-acting.
I'd like to remind everybody of Dr. Schneider's comments yesterday about vitamin C. And, you know, vitamin C seems like an innocuous substance, and yet when he did a controlled study, vitamin C was actually worse for patients with cystinosis. And so I don't think it's a good idea, not that you can extrapolate and may be totally different, but still, running out and giving your kid a lot of vitamin D may not be the right thing right now. It should be done in a controlled study.
Right.
Dr. Mack, on your chart there were examples of successful bone marrow transplantation and then unsuccessful. In the cases where it was unsuccessful, what are the repercussions?
So first of all, it comes back to the matter of, are you getting enough enzyme and where it's needed? And in most of those cases, although the transplant itself may have been successful, the enzyme wasn't getting where it's needed, so the disease continued to progress. And that's the most common outcome, is you didn't make a difference or you made a little bit of a difference. We have some diseases where the person continued to deteriorate, but there's just enough enzyme that it kept a person from going all the way through the disease course and left them in a horrible state where they were blind and were not able to interact. And so there's always dangers when you don't know what lies ahead. Sometimes, you know, when you're going to cure, you want to make sure that you're going to be able to get the cure, and you're not going to lock somebody into a state where the quality of life becomes so horrible and you get sort of the worst of both worlds. And that's the most tragic outcome. Usually though, in those transplants that don't work, for example, we performed them in the past for Tay-Sachs. And we saw a change, and children did better for a while, but they still ended up deteriorating. And what it did is actually made the deterioration much more slow than it would be if we hadn't done anything at all. So that in some ways one could say that you prolonged a period of time where someone was suffering. Other people would say, you know what, I was with my loved one longer, and so that was nice, but it was the quality of life. And so we're looking not only at quantity of life, but quality of life. They also then put on top of the fact that doing a transplant, there are sometimes long-term sequelae from doing the transplant. So from the problem itself, you may give someone that graft versus host, where the immune system attacks the person. Although usually we have tolerance, sometimes that persists indefinitely and can, again, impact somebody's quality of life.
I have a question for Dr. Salome. So some patients, when after transplantation, kidney transplantation, they, because they still have their own kidney, their native kidney, they still have proximal tubulopathy. So sometimes they have to go through a surgery again to remove their kidney. So why don't the physician remove their native kidney because they have cystinosis and they have a risk of proximal tubulopathy? Is this risky?
Yeah, that's a really good question. First of all, doing a native kidney resection is a big surgery. Because the kidneys are on both sides, so you really have to open the abdomen up. I can't really go, I can take one kidney out from the back, like with a laparoscope, but not both of them. So you have to go in and make a midline incision, and you're in the abdomen, it's a mess. So you don't want to do this if you don't have to. The second thing is, the good news is that usually what happens with end-stage renal disease is that it's a matter of time. If you wait just a little bit longer, the native kidneys kind of die away, and the kidney transplant accelerates that process. So if you just are a little patient for the few kids that still have some function and it's a problem, and that does happen, we see that with other native diseases, so it's a great question. Usually you just wait it out, and then the kidney will kind of die away, and the transplant will be functioning.
I think maybe related to that, there was a question about the pros and cons of nephrectomy, how it relates to Fanconi syndrome, and as a result, should we have this done before transplant, and if so, do you remove one or both kidneys?
So if you had a choice, another really good question. We see this in a couple different kidney situations where there's a lot of proteinuria, and the proteinuria drove us to the transplant kind of ahead of the renal failure. And it's a mess, you know, because you're losing protein and you're edematous, and there's all kinds of, it's not very pleasant. The problem is this. The kidney, even when it's near dead, is making a lot of erythropoietin and also metabolizing certain drugs. So what we've known for years is that you're, even certainly on dialysis, you are better off with your native kidneys than without them. The complication rates, the quality of life on dialysis is better when you have your native kidneys than when you don't. So there's an argument from that alone not to take the native kidneys out and then add the complications of the surgery, but that's notwithstanding. It's just even having the native kidneys there is a good thing for you. So we're not really excited about doing that. I think after that it would be a really set of individual questions. Is there a situation once in a while where it might happen? I can't say that. It may be. If there is, I'd just add, by the way, that we can also do this non-invasively now. You put up a catheter into the kidneys and you embolize them. And you basically kill the kidneys without the surgery. So if we have to do it, and you said, well, Dan, you said I had to do the operative surgery, and I said, well, actually, I was lying, and you can do it without the surgery. So.
I have a question for Dr. Moore. You emphasized how you're anxious to get the patients out of the hospital to send them home. What if the patient comes from the East Coast and is very far away? When you say home, are you talking about people who live relatively close to your hospital? Does that make a difference?
I used home generically. UCLA is a home away from home.
Okay.
That's an outstanding question. When we say home, we mean out of the hospital and away from risk of acquiring super germs that could be in the hospital. And even though all the rooms are cleaned down and such, you're usually safer in a protected environment. But yes, we want people close around to where we're at. There are follow-up studies that we need to do. Now, when we can, when we feel it's safe, there are folk all across the country that can manage bone marrow transplant patients. There's nothing very unique about that to Southern California, of course, and so we would work with other folks' physicians, but there would still be required follow-up studies that need to be done.
Actually, I have a question for Dr. Moore. Stephanie did it to me a minute ago. The question is, when you presented it, you were saying that you're going to do the bone marrow harvest, right? So you can also do peripheral blood mobilization. So could you talk a little bit about why did we choose to do, because that was, we deferred to you.
Remind us what peripheral blood mobilization.
The old peripheral blood mobilization trick.
That's the problem when you just let them talk amongst themselves.
So as was brilliantly explained by Dr. Simpson earlier, there are 3 stem cell sources we use. We use cord blood, we use bone marrow, and we use peripheral blood stem cells. And it turns out that peripheral blood stem cells do engraft faster than bone marrow. They engraft more blood products sooner. And so in many ways, it looks like that would be what you'd want to use, because you could recover more quickly. However, studies show in patients now for 15 years of follow-up through the National Marrow Donor Program that people who receive peripheral blood stem cell transplants have a higher rate of the chronic graft versus host disease. So each of these 3 products are a little bit different. Cord blood bone marrow and peripheral blood stem cells. And the peripheral blood stem cells have 1 log or 10 times more of the T lymphocytes in that product going into the patient than the bone marrow does. And so because that's what we're theorizing plays a role in the higher chronic graft versus host disease. And so that's then puts a person into a chronic inflammatory state long term, which probably isn't a great idea in this disease. So that's why we pick
So the
bone
cord
marrow.
blood comes at birth and you store it, right?
Correct.
So that's obviously not an option really for anybody in this room. And then the stem cells come from?
Stem cells come from the donor. But instead of going to the operating room and harvesting bone marrow, the plus side of the stem cells is you get 2 IVs. You are hooked up to a machine for about 2 to 4 hours, and enough cells are collected for the transplant.
And then where do
the downside, and those are stored and frozen away, and then infused into the patient. The downside, though, is that in the long term, if you follow people out long enough, that may not be the best choice for non-malignant diseases. It turns out in some of the malignant diseases, those extra T lymphocytes may be helpful in killing the malignancy.
And then where does the peripheral blood cells come from?
So peripheral blood cells would come from the donor. You'd put IVs into the donor. It would go through a machine that would collect the cells needed for transplant and give everything back to the donor.
Gotcha.
And then that would be infused in just like a blood transfusion.
For those of you who have donated plasma in college to raise money to be able to drink beer, similar process. Not that I ever did.
Except we get the alcohol out first.
Somebody wrote, we'd like to learn more about starting Indomethacin therapy. The risk versus benefit, which I think in Europe isn't rather common, and here it's less. Indomethacin.
I know in France, almost all the cystinosis patients are on Indomethacin, and it's because these kids find it very difficult, most of them, to get through the night without bedwetting. They put out such a huge amount of urine, and this can markedly lower the urine volume. But there are side effects, and 2 of you in the room here today have, I put your children on it, and each had a different side effect after a while. So you have to watch the patients very carefully. And doctors in the United States, generally nephrologists, are really hesitant to do this because they feel that it's damaging the renal glomeruli. Doctors in France think it simply lowers the renal blood flow, and because of that lowers the GFR. But that once they stop the drug, the GFR returns to normal, and they watch the patients very carefully. So the important thing is to find a doctor who has experience and feels comfortable doing it.
So my comment as a nephrologist would be cautiously don't do it.
Man, a few words. I have a follow-up question.
My comment as a gastroenterologist is that Indomethacin is a very potent gastric irritant, very common cause of gastric and duodenal ulcers and upper gastrointestinal bleeding. So also, try not to do it.
All in favor?
That's one of the common side effects.
I got a follow-up back here.
Given all of that, if we decide we'd like to try it anyway, how do I find a doctor to support us in getting on the therapy here in the US, or maybe even a doctor from Europe who would be willing to consult with our doctor here in the US? I'm struggling to find that person.
Well, we once actually did a study on Indomethacin, and the person in France who was helpful to us was Patrick Niaday at the Children's Hospital in Paris, who had been head of pediatric nephrology, and I understand he's just retired. And give me your doctor's name or your name, and I'll get information about him. I know he spent a year in London. He speaks English very well, and he has a lot of experience doing this, and he'd be the type of person I would talk to.
Thank you.
Okay, I need to watch it to know what we're doing time-wise here.
12:03.
Okay, so we probably need to take a couple more and then wrap it up. Do you agree? Okay, so if Cystagon is or was used as an antidote for Tylenol, historically, does it negate the effects of Tylenol when given to children with cystinosis? If so, what should we give our children in place of Tylenol when it's needed?
We did that one yesterday.
Oh, we did?
Yep.
Must have been.
Sorry about that.
That's okay. You go for
They
the
can
next
continue
one.
to use. Dan, what is nephrotoxicity? And is this something that cystinosis patients are more prone towards?
Yeah, nephrotoxicity is just a simple term, means kidney toxicity or injury to the kidney. And if you have an underlying progressive kidney injury, the addition of other toxins would obviously be less well tolerated by a child. So you would like to avoid it.
Okay, any idea, just off chance, how many adults or kids have IBS or IB disease?
So can you repeat that?
IBS?
Any idea how many kids or adults might have something called IBS or IB disease?
IB.
Irritable bowel syndrome, maybe? Is that
Irritable bowel.
No, I know IBS. What's the last one? IB.
irritable bowel?
Okay.
Yeah.
So a lot of people. So currently, irritable bowel in the adult population accounts for the second commonest reason why adults miss work. Occurs in about 20% of the population. In adolescents, probably about 10 to 15%. So irritable bowel is not an inflammatory disorder, so not to be confused with inflammatory bowel disease. It's a functional disorder where you get symptoms such as diarrhea, bloating, abdominal pain. Sometimes you can get upper gastrointestinal symptoms, nausea, vomiting, reflux type symptoms. So very common, and if you have cystinosis, well then you probably would have slightly higher risk than 15 or 20% chance of having it because you have other stress factors which may contribute to it, such as having cystinosis. But in the normal population, 15 to 20%.
I think I got two relatively quick ones, and then that's all I've got. But people have heard about heart issues. Any heart issues that you guys are aware of, maybe, and if so, at what age? Eat right, take your vitamins. Is that what you're saying?
I don't have much to say. I think there have been reports of cystinosis patients who've had cardiac problems, but they're very, very rare reports. I mean, all muscles are involved, and there's no reason to think that myocardium wouldn't also be involved. But I've not thought of this as a major issue with cystinosis.
And then last one, there are children with cystinosis who have knock, knees, and leg pain. Some have surgery and pins to correct the problem. What can we do to prevent this?
I think careful follow-up with vitamin D. I have nothing else.
That's rickets, right?
Yes.
Yeah.
Yeah, I mean, the answer is early diagnosis. I mean, if these children are diagnosed early enough, and that's the big push for prenatal or just immediate natal testing, is that you start these kids on vitamin D really early before, and one of the things that I've really learned from my contact with the families and the children is that a lot of you have taken years before you finally got the right diagnosis, and we really hope that ends. That's a tragedy that I think we need to fix. So, if you start early enough, you should never develop rickets anymore.
I think there's a follow-up.
Hi, I actually asked that question, and I think Dr. Grimm yesterday answered that for me when he talked about the bicarb, like keeping it high enough so that you're not in that state of taking the bone away to, and I think that's what, I don't know if that made sense, but so keeping those levels in the, normal zone helps keep your bones strong. So.
Thank you.
So there's another reason for these problems in addition to the bone problem, which is the biggest one. These kids have low muscle tone, a lot of them, when they're young, and that can contribute to abnormal posture, especially of the legs and feet. The feet can be flat, the legs can be bowing back because of the low muscle tone. And so if that's the case, and if that's contributing to the gait problems and the posture problems, working with physical therapy early on can help that.
Okay, I'm sure there are a few people out there who have more questions, and I know most of these people are going to be around during the lunch hour and perhaps beyond. My experience with this whole group and the Cystinosis Research Foundation is how people come together that typically might not have the opportunity to do so. The fact that all of us parents and patients are sitting in front of the people who are doing all this amazing research is really unique and special, and we are really, really lucky. So thank you for sharing your knowledge with all of us and taking the time and keeping it in layman's terms, and thank all of you for asking the questions because it helps everybody. So we're just grateful. And I think we should go have lunch. Right? Oh, wait.